Good morning. My name is Sarah Widoff. I'm one of the RN LVAD coordinators at Seton Heart Specialty Care and Transplant Center. I'm here today to talk to you about the role that EMS plays in providing care for our LVAD patients in the community, as well as to talk about both HeartMate 2 and HeartWare HVAD LVAD devices. Our goals today are for you to know how to reach us in an emergency situation. I want to give you an overview of the parts and pieces and how they work. We'll talk about alarms and how to respond to them. We'll talk about ACLS as it applies to this patient population and prepare a patient for transport to Seton, Maine. I have no conflicts of interest to claim today. Seton has been doing heart transplants since the late 80s and placing LVADs since the early 90s. These numbers are a little bit out of date. We are well over 400 heart transplants, and we have implanted close to 400 LVAD devices as of September of 2017. As you can see, though, many patients who receive LVADs do not go on to receive transplants, which is part of why this patient population is growing. When we treat heart failure patients, there are a variety of options available. We start with lifestyle changes, which are simultaneously the easiest recommendations for us to make as healthcare providers, but simultaneously very difficult for patients to actually do. And those lifestyle changes include tracking daily weights, following a 2-liter fluid restriction, and following a 2-gram sodium diet. Medications that we use to treat these patients include diuretics, beta blockers, ACE inhibitors, and surgical options include placing pacemakers and defibrillators, doing a heart cath to intervene if possible, replacing valves as needed, and then doing bypass surgery and placing LVADs and moving on to transplant. LVAD patients fall into one of 3 categories. Bridge to recovery patients are patients who have suffered some sort of acute insult to the heart, whether it's an acute MI or something like the flu. And these patients receive an LVAD to allow their hearts to rest, and then that device is removed when they've recovered heart function. You will not see these patients in the community. Bridge to transplant patients are listed for heart transplant at the time they receive an LVAD, and destination therapy patients are not eligible for a heart transplant for whatever reason. In order to be a bridge to transplant patient, patients must qualify in terms of having adequate lung function, liver function, and kidney function. As you can see, many patients are listed, and there are an average of 18 people who pass away every day waiting for an organ transplant. And so LVAD came into use to buy these patients time to receive their heart transplant. And we use both HeartMate 2 and HeartWare HVAD for these patients. Destination therapy patients are not eligible for heart transplant, whether it's because their BMI is too high, they've been smoking, or their diabetes is out of control. These patients are typically dependent on IV inotropes, and they have class 4 heart failure symptoms, meaning that they're short of breath at rest. We use HeartMate 2 for this patient population, and the HeartWare HVAD trial for DT was just finished and just approved for destination therapy as well. There are 2 different types of LVADs in terms of how they function. Continuous flow devices include HeartMate 2 and HeartWare HVAD. And what continuous flow means is that there is a piece inside the pump, typically some sort of rotor, that moves continuously. It moves the blood, and there is no pumping action. This is a picture of the HeartMate 2, and you can see the pump housed just underneath the left ventricle. The inflow cannula is placed in the left ventricle, and the outflow cannula is anastomosed to the ascending aorta. The driveline tunnels through the abdomen and connects to the controller outside of the belly, and then the controller connects to the 2 batteries that you can see in the holsters here. Here you can see the continuous flow part of the HeartMate 2, and this is the rotor that spins continuously to move blood from the left ventricle up to the aorta. This is the HeartMate 2 system controller, and I want to start by going through the lights and the buttons and what they mean and what they do. I'll start with our green circle of life up here at the top. This tells us that the controller is plugged into power, the driveline is plugged in, and everything is working properly. This light should always be on. And when you respond to a patient's call, this is one of the first things that I'll ask you is your green circle of life on? The battery button here has 2 functions. It lights up the bars to tell you how much battery power you have. Each bar is representative of 25% of the battery life. It also does our daily self-test if we press and hold it down, and the patients should be doing that every day at home. There are 2 low battery warnings. One is this yellow diamond, that's your 15-minute indicator. and the red battery comes on when you have 5 minutes left. Our broken red heart here goes off when there is something wrong with the pump itself. Typically that's a low flow alarm. As you can see on this controller, our yellow wrench is alarming. And what that means is that there's a computer glitch with the controller itself. Our silence button works to silence the alarms. It doesn't fix any alarm condition, but it just makes everything be quiet so that we can talk on the phone, hear each other, and troubleshoot appropriately. Our screen here is your display. As you can see, it's displaying the error message related to this yellow wrench alarm, backup battery fault. The other thing that we can do with this square button over here is scroll through our VAD numbers. The first number that comes up is the speed. We're measuring how fast that rotor is spinning. That is set for the patient, and it shouldn't vary, but by a little tiny bit. This pump is set at 9600. Currently it's running at 9590. The second number that comes up is the flow. It's important to know that there is not a flow probe inside this pump, but we are approximating how much blood in liters per minute is going through that pump. As you can see right now, 5.7 liters per minute. I like for it to be above 3. The low flow alarm goes off at 2.5. The third number that comes up is PI. PI is a number that was invented to quantify the pulsatility of the left ventricle underneath the pump itself. Because this is a made-up number, we typically don't treat patients based solely on it, but I do like for it to be above 3. As you can see on this mock loop, our PI is only 2.2 because there's no pulsatility in this loop. The fourth number that comes up is the pump power, and this is arguably the most important number that the VAD will give you. What we're measuring is power consumption of the pump. How much power is the pump using to achieve that set speed, in this case of 9600. We were at 6.1 watts. And the reason that I worry about that is because if the speed isn't changing, but the pump needs more power to get there, then I'm concerned about some sort of obstruction. And that obstruction could be a blood clot that's forming on the rotor of the pump, or it could be high blood pressure that's acting like an obstruction. Another feature of this controller is the alarm history menu, and you access that by pressing your silence button and your square button at the same time. And that pulls up the last 6 alarms that the patient had. As you can see, it date and time stamps the alarm. It tells you what the alarm was and how long it lasted. This is handy because patients will sometimes call and say, my controller alarmed, but by the time I got it out, the alarm had stopped. And so that lets us see what the alarm was that the patient was hearing. Here I also have the batteries connected to the controller. A pair of batteries lasts for 10 to 12 hours. Another thing that I wanted to demonstrate today is how to change the HeartMate 2 controller. I have this controller specifically set to give us a yellow wrench alarm. And so I'll reset the silence so that you can hear what it sounds like. So this is what our yellow wrench alarm sounds like. This could potentially be a situation where the patient needs to change their controller at home. The first thing I'm going to do is silence this alarm so that we can talk over the phone. The next thing we need to do is to find the patient's backup equipment. They should have a backup controller and 2 extra fully charged batteries handy. Before we start unplugging anything, we want the patient to lay down or sit down so that if they do pass out when their pump is disconnected, they don't fall and hurt themselves. Once we've done that, I like to lay the controllers out right next to each other so that we're not fumbling for anything when we move that drive line over. And then finally, we need to plug the controller we're going to switch to into batteries so that the new controller has power connected to it. Okay, now we're all set. One of the safety features of the HeartMate 2 is this trap door, and this trap door protects the red button, which must be pressed and held down in order to remove the driveline from the controller itself. So as you can see, even with the trap door open, that driveline will not be disconnected unless I'm pressing and holding this red button. Before I disconnect the driveline, I also want to talk about the markers that you'll look for when you do switch controllers. You can see this black arrow here on the controller that we're currently connected to. There is a similar black arrow on the controller that we're going to move towards, and that's what you're going to aim for. When I disconnect this driveline, you will also see a black arrow appear on the driveline itself. And so that's the arrow you're going to line up on the other controller. So start to finish, it looks like this. Open the trap door, press the button, pull the driveline out. There's our arrow. Line the arrows up. Use your silence buttons to silence the alarms. Once you have the driveline firmly plugged in, you should hear it click. You should be able to shut your trap door. That's an additional safety feature. If the driveline is not completely plugged in, but it's plugged in enough that it's not alarming, you won't be able to shut your trap door. So after you've finished reconnecting the driveline, one of the things I'll ask you is, does your trap door shut? Yes, great, we're good to go. The next thing we're going to check is our green circle of life on our new controller. Yes, okay, great, we're good to go, and you've successfully reconnected that driveline. There's one final step in this process. This controller thinks that it should still have a driveline plugged into it, and it's going to alarm at you every 2 minutes until you tell it that it doesn't need to have a driveline plugged in. In order to put this controller to sleep, the first thing we have to do is disconnect our batteries from it. It has to be completely disconnected from power. Now we're going to press and hold the battery button, and it's going to count down. And now it's asleep and it won't alarm anymore. My job from here is to provide the patient with a new backup controller. This is the other type of LVAD that we place at Seton, called the Heartwear HVAD. It's very similar, it just looks a little bit different. As you can see from this picture, it's placed right into the pericardial space, right up against the left ventricle, and then still at anastomosis to the ascending aorta. There's still a driveline, and there's still a controller and 2 batteries. This is what the HVAD pump looks like, and as you can see, it's designed differently. But we still have a rotor that's spinning continuously. The biggest difference, of course, is that it's a much smaller pump. This is our HVAD controller. It's very similar to the HeartMate 2 controller, but a little bit different in some ways. We still have an alarm silence button. We have battery indicators at the top here, and as you can see, this controller is alarming at me because one of my batteries is low. Our alarm indicator, our triangle here in the center, will turn either yellow, orange, or red depending on the status of the alarm. This is the toggle button over here. And our arrow button, our toggle button, allows us to scroll between the various menus. When we change an HVAD controller, the process is very similar to changing a HeartMate 2 controller. The first thing you're going to do is find the patient's backup controller. And the second thing you're going to do is have the patient lay down or sit down so that if they pass out while their pump is disconnected, they don't fall and hurt themselves. When we change an HVAD controller, we use the 4 Ps. And those Ps stand for pacifier, power, patient, and power. And so we're going to change the controller in that order. There are a couple of differences I want to talk about before I actually move the driveline over. This pacifier is how we put the HVAD controller to sleep, so that's a little bit different than the HeartMate 2. And so the first thing we'll do is we'll move the pacifier to the blue port of the controller that the patient is currently hooked up to. Then we'll move one of the batteries. It's a spring-loaded lock mechanism, very simple, just a gentle twist to disconnect, and it pushes straight in to reconnect. The driveline is a little bit different. There's no trap door. We're going to grab the driveline by this ridged section here and pull it firmly to disconnect it. You'll see a red dot on the driveline there, and there will be a corresponding red dot on the port of the controller right there. So all put together, it looks like this. Pacifier, power, patient, power. So why do these patients call EMS? Our 3 biggest concerns are for infection, bleeding, and stroke. Driveline infections can be extremely life-threatening for these patients. So any symptoms of infection that's progressing to sepsis, including fever, mental status changes, and other indications of infection would be a reason for the patients to call EMS and to come to the emergency room. Damage to the driveline is also a life-threatening emergency. I have seen patients cut through their drivelines completely by accident, but if those wires are damaged, the pump will stop working, and the only option is to go in surgically and replace the pump. In terms of bleeding, we see things as straightforward as nosebleeds, which can be treated at home. Bleeding cuts, scrapes, and injection sites, and any sort of trauma is more likely to bleed in these patients. GI bleeding is also a huge problem for these patients, and it will often go undetected, resulting in something like a syncopal event that would lead them to call 911. These patients can present with both ischemic or hemorrhagic strokes. Right heart failure is also possible because the right side of the heart is not supported by this pump. And any sort of malfunction within the pump will cause their heart failure symptoms to recur. When you arrive on the scene, assessing the pump is something that we can help you with over the phone, and we'll talk through all of these questions, making sure that the driveline is plugged in and that that's not the source of an alarm, that if it's a HeartMate 2 device, our green circle of life is lit, the power cables are firmly plugged in to charged batteries. In terms of switching controllers, I will demonstrate that today, but that is something that we don't want you to do without us on the phone so that we can assist you, as there's a high potential for things to go wrong in that situation. And always use your silence button to silence the alarms. You can use your stethoscope to listen for the VAD hum. Both of these pumps will be audible using a stethoscope over the chest, typically loudest over the left upper quadrant, and it should sound like a whirring or a buzzing noise. It has a mechanical sound to it, but it should have a smooth, constant pitch, and any grinding or ice in a blender sound is extremely concerning for clot. Listening for the hum is a way to verify whether or not the pump is working if there's a malfunction with the controller and you're not sure. When we assess these patients, there are a few key differences to be aware of. These patients probably will not have a palpable pulse. Using a Doppler is the best way to assess for circulation, whether it's a general assessment or during CPR and ACLS. Other signs of perfusion that you can look for in your patient include capillary refill and looking to see that your patient is pink, warm, and dry. Blood pressure is also different because of the continuous flow feature of the pump. We take blood pressure in these patients by using a Doppler, and you're only going to get one number, and that number is charted as, for example, 72/D for Doppler. The number that you get is most similar to a map, but it's not a true map, and our goal is 60 to 80. If these patients are hypotensive, they may need fluids, and if they're hypertensive, they may need treatment as well. Your EKG should read accurately. Sometimes there's some electrical artifact from the pump, but any arrhythmias that you see on your EKG should be treated. Know, however, that most of these patients do have fully functional ICDs. Because your O2 sat is based off of pulsatility, you may or may not get a good O2 sat reading on these patients. Sometimes the forehead or the ear probes work better. If your waveform matches the EKG, then your pulse ox is probably accurate. If not, then you'll want to look for other signs of adequate oxygenation, such as respiratory rate and pattern and mental status. For pulmonary assessment, there's no real difference in these patients. You may not be able to hear lung sounds clearly over the pump, and it's appropriate to chart that. We also categorize these patients in terms of being pump dependent versus having pulsatile flow. And what that means is patients that are extremely pump dependent, if they have any interruption in the function of their pump, if their pump stops, they will pass out. And it's important to know that when we're changing controllers because we need to be prepared for that situation. If a patient is more pulsatile, that means that they have more underlying native function and they are less likely to pass out when you unplug their driveline to change their controller. Unfortunately, we don't have any way of knowing which category the patients will fall into until the worst happens and we have to change their controller. When you're assessing these patients, the bottom line is to trust your gut. If a patient doesn't look like they're doing well, doesn't look like they are stable enough to remain at home, let us know that, and we'll support you guys in bringing these patients into the emergency room. It's important to start assessing the patient and to work backwards from there to the pump. The pump obviously is important. The origin of the problem is typically within the patient and not on the part of the pump. Know that these patients are all anticoagulated with Coumadin. We also use Lovenox as a bridge for low INRs, and our goal is typically 2 to 3. Most of these patients have functional ICDs, but they can still be shocked externally if their defibrillator does not go off. They can be given ACLS drugs, and ACLS protocols can be followed without any changes. At Seton, we do chest compressions on our LVAD patients, but that varies from program to program. The concern is that the inflow cannula may become dislodged while you're doing chest compressions, but the literature suggests that that's really only a concern in the immediate post-operative phase. And by the time the patient's at home, enough scar tissue has set in to prevent the inflow cannula from becoming dislodged. When giving these patients fluid, remember that this is still a heart failure patient. It's possible to overwhelm the right ventricle since it's not supported by the pump, and that in turn can lead to left ventricular failure as well as flash pulmonary edema. In order to reach us, there are 2 phone numbers that you can use. The 797 number is a flip phone that comes directly to the pocket of whichever VAD coordinator is on call, and that number works 24/7, 365. Another way to get us is to go through our main office number, which is this 681-0500 number, and option 2, after hours, will still get you to the 797 number and directly to the coordinator on call. When you arrive on the scene, identify the family member who's been trained and who can assist you. That person will be helpful for locating the backup controller and for knowing important details about the patient. Try to get a blood pressure, and remember that your EKG should be treated. And if all else fails and the patient's unresponsive, start CPR. These patients can be transported via ground EMS if they're stable. They can also be flown if necessary. If there's time, please gather all of the patient's equipment. If not, the only vital piece of equipment is this black backup bag. And that backup bag has the patient's backup controller and an extra set of fully charged batteries that needs to go with the patient everywhere. If at all possible, please bring the patient directly to Seton, Maine on 38th Street. If we need to stop at a Seton ER on the way, such as Seton Williamson or Seton Hayes, that's possible and those emergency rooms have been trained. I want to speak briefly about patients who have chosen to withdraw care at home. These patients should be on hospice care and should not be calling EMS. But in the event that they do, know that these patients may be under hospice care at home, getting ready to pass away. If the patient passes while the VAD is still on, give us a call and we can help you disconnect it and silence the alarms. The equipment belongs to the family and should stay with them. There are several additional resources available for you for further education. The website mylvad.com is run by patients for patients, and they have a great emergency medical services page. They also have the Field Guides master document, which gives you a quick and dirty page on every type of VAD device that you may see in the community. Both of the device manufacturers have good websites, including thoratechu.com, which has EMS-specific videos, as well as the heartware.com website.